Get started. Welcome to Smilow Shares with Primary Care. Just an introduction to this series. Smilow Shares with Primary Care is a collaboration between primary care and oncology here at Yale. I'm Karen Brown, a primary care internist, and I work with Ann Chang, an oncologist and the Associate Cancer Center Director for Clinical Initiatives. We are happy to present today's topic, which is gammopathies. Our perspective in cancer care is distinct in primary care. We're constantly providing advice to prevent cancer, testing to screen for cancer, testing for cancer, and fortunately, far less often actually finding new cancer. Diagnosing a new cancer, whether by screening or due to a patient complaint, is a time where we want to be as efficient as possible to get our patients to the treatment they need. We are delighted that Dr. Chang and our oncology colleagues are interested and willing to explore this interface of care with us in this series. During the talk, please feel free to enter your questions into the chat, and we will look at those at the end of the talk. We'll try to save some time. I'd like to introduce my primary care colleague, Dr. Drew Cutney. Dr. Cutney is board certified in internal medicine and pediatrics and a very valuable member of our Northeast Medical Group primary care community. My own first memory of him is he knew how to use Epic better than anybody else, before anybody else did. He's been with us since 2008 and practices primary care in Trumbull, Connecticut at the Park Avenue Medical Center. And I'll turn it over to you and to introduce our other panelists.
Great. Thanks so much for joining us tonight and for continuing to access this series online. I have the honor of introducing the hematologists tonight that are joining us. Dr. Sabrina Browning, that's on the right. She is Assistant Professor of Medicine in Hematology, and she received her medical degree from UConn, and then her internship and residency completed at Yale New Haven Hospital. After residency, she served as an amyloid fellow at the internationally recognized amyloidosis Center at BU and Boston Medical Center. And then she returned to Yale New Haven Hospital to complete her fellowship in medical oncology and hematology. She's a physician in the Smilow multiple myeloma and Gammopathies program, and her clinical and research interests include evaluating new treatments for multiple myeloma, amyloidosis, and other hematologic diseases. Also, I would like to introduce Dr. Noffar Bar, who's an assistant professor of medicine and hematology at the Yale School of Medicine. She completed her internship and residency at the Mount Sinai Hospital and her fellowship at Yale, and received her medical degree from the American Medical Program at Tel Aviv University in New York. She's a member of ASCO, the American Society of Hematology, the International Myeloma Society, and her research is focused on multiple myeloma and other plasma cell disorders. And she specializes in all treatment modalities for myeloma, including CAR-T, cell therapy, and stem cell transplant. She'll talk a little bit about those as well tonight. So we've got a great program for you tonight. Save up your questions. You always have some excellent ones. And I will now turn it over to Dr. Barr to sort of set us up with what we're going to do tonight. Thank you.
Thank you, Anne, and thank you for having us. Today, some of the key points I want to highlight is reviewing the reference ranges for serum-free light chains, and this can be affected by age and renal dysfunction. Second, discuss some of the differences between IgG, IgA versus IgM monoclonal gammopathies, define low-risk MGUS, and discuss how this could be managed by the primary care physician, discuss some red flags that warrant more urgent referral to hematology, and also review this EPIC monoclonal gammopathy pathway we've developed recently and provide, hopefully you can provide us some feedback over time. So to begin, I want to start with some background. And monoclonal gammopathies, for the most part, are driven by clonal or abnormal plasma cells within the bone marrow. And they secrete a monoclonal protein called an M spike or M protein, as I show you here. And this is a picture of either an IgG or an IgA. And you can see that a part of the whole antibody is also the light chains, which is important. I mentioned that most gammopathies are from plasma cells. There are several gammopathies that originate from B cells, clonal B cells, but for the most part, plasma cells. Now, when you're thinking about a monoclonal gammopathy, this is the paraprotein evaluation. We do a serum protein electrophoresis, and I show you here what would be normal on the left, and on the right, an abnormal spike in the gamma region. There is some differences with gammopathies. For example, IgAs often come in the beta region over here, if you see this, and you see the two spikes. That actually makes it a little bit more difficult and often underrepresents IgA gammopathy. So just some key points there. The immunofixation below identifies the clone. Okay, so the SBAP quantifies it. The immunofixation identifies, for example, here we see an IgG kappa. In addition to this, we also need to have a serum-free light chains. We do not check urine-free light chains anymore. And the importance of this one, it helps us with some risk stratification, diagnosis of myeloma, but also there's a few patients, about 20% of myeloma, that presents only with light chain secretion. So you might miss a diagnosis of a gammopathy if you're not checking the light chains. Additionally, it's important to note, and this is kind of not something you think about, but different labs have different ranges of abnormalities because the units are different. So for example, Yale uses milligrams per deciliter, but Quest, which some of our patients use, uses milligrams per liter. So like 60 at Quest is 6 at Yale. So that's important to recognize. And some patients will say, oh my God, 80, but it's really 8. So it's important to compare apples and not apples and oranges. The definition of abnormal light chain ratio depends on age, and here is some information from a recent analysis in Iceland, where they are testing everyone for monoclonal gammopathy, and they saw that patients who are older tend to have a higher light chain ratio. As you can see here, the higher end is 2.5, and as a reference range of what's normal in our lab is 1.65. Additionally, creatinine clearance affects light chain ratios. You can see with that lower creatinine clearance or worse renal function, the ratio gets higher at 3.3. So when you have someone with normal IFE and a light chain ratio of 2.5, well, it is abnormal in our lab. If they're older or have renal dysfunction, it might actually be normal. So this is the spectrum of monoclonal gammopathies. It's not all inclusive, but it's representing the most common gammopathies. You can see here at the end multiple myeloma, which is the cancer, but on the right is the first or initial precursor state of what we call MGUS, monoclonal gammopathy of undetermined significance, and then it goes through an intermediary stage of smoldering myeloma. With both of these, MGUS and smoldering, another name for smoldering is asymptomatic myeloma. These are precursor states and are not representing cancer and do not need to be treated. And these do not have CRAB criteria, which we'll talk about soon. The major difference when you're evaluating the bone marrow in these patients and part of the diagnosis is that there are less clonal plasma cells with MGUS and more clonal plasma cells with smoldering, less than 10 or more than 10%. And what's relevant for the patient is the risk for progression. 1% with MGUS, 10% on average per year with smoldering. So I think most of you know that the definition of myeloma requires a clonal plasma cell clone of clonal plasma cells in the bone marrow of more than 10%, in addition to one or more of the CRAB criteria, including high calcium level, renal insufficiency, anemia, and bony disease. However, about a decade ago now, the definition of myeloma actually changed. And now we have what's called the slim CRAB. So for those of you who don't know what the slim CRAB criteria is, I like to go backwards to review the spectrum of gammopathies to really understand where this limb crab came from. And here you can see that the smoldering myeloma is actually a very heterogeneous group of patients. While on average 10% progress to myeloma, there are some patients that behave like MGUS and will never progress, and some patients progress within 1 to 2 years and probably should be diagnosed as myeloma. And that is exactly where the SLIM criteria came from. Researchers identified factors that led to a risk of progression of myeloma at 2 years at 80%. And they said, this is unacceptable and patients should be treated for myeloma. And this is 60% clonal plasma cells in the bone marrow or more, a light chain ratio over 100, and having more than one bony lesion on advanced imaging like whole body MRI, PET scan. So with that, we will move forward to our cases.
Thanks, Noffar. So before we get into this case, just want to give a brief context of the 4 cases that I'm going to bring in. And these are all cases from a panel. They're relatively fresh, which means that they're either a new diagnosis of a monoclonal gammopathy, or it's a new patient to me that I had to get to know, or it's either a change in the clinical status that has happened recently. And the one thing I just want to have you pay attention to is, pay attention to crab criteria as we go through the cases, but also they don't fit 100% by the book necessarily, and I think that goes along with a lot of patients that we see. We're always trying to figure out what's going on from noise. And their diseases vary and don't go by our strict criteria 100% all the time. But they do represent key points and pearls. So with that, we'll jump into our first case. And this was a 50-year-old Hispanic female that was new to me in 2021. And for the most part, she was, it was well known that she had MS that was diagnosed in 2019. And we talked about that quite a bit. She had presented with incapacitating migraines at that point, with vertigo, which prompted the MRI and confirmed a diagnosis. And she started on Ocrevus, which is for therapy every 6 months, and had no disease progression, and it was otherwise stable. Her history otherwise was non-contributory. She had a cervical fusion in 2017, and she had a C-section in 1994. Her family history was notable just for hypertension, hyperlipidemia, heart disease, some substance addiction. And she herself was married. She had a son. She worked in an office setting. She had a 10-pack year tobacco history, but had quit in 2011. And she's locally born and raised. Next slide. And so in the last fall in 2024, she came to me with 6 months of a chronic cough and this persistent, frequently recurrent bilateral otitis externa, where her external ears were just swollen closed, very tender, really hurting. And she was at her wit's end, not only from the ears, but she had this cough that was relentless, a lot of abdominal pain, couldn't sleep, it was dry cough, just unmitigating. And she had seen neurology, ear, nose, and throat, and immunology for these things. And when she was coming to me, she was asking me a lot of questions about that workup. So I saw her, we looked at the cough, looked like it turned out to be a really strong GERD trigger, and some allergic postnasal drip. So we addressed that. And then the recurrent otitis through some Pseudomonas and, sensitive staph, oxacillin sensitive staph, and we just treated those accordingly. We got the cough under control, and the ears, we had a regimen that settled down. But during the subspecialty evaluation, she was found to have suppressed B cell presence on her flow cytometry. And she had a low IgG2 subclass. And then they challenged that with a pneumococcal conjugate vaccine, and no antibody responded. So the theory was that this was from her Ocrevus, it was suppressing her B cell colonies, and that in turn was causing these recurrent otitis externas. Now, the interesting thing here is that on her SPEP and her immunofixation, she had an IgA kappa monoclonal protein. So next slide. And the key points to the eval is that she was not anemic, she had good renal function, she had normal calcium levels. There are no discrete monoclonal bands identified on the SPEP, but on the immunofixation, there was IgA kappa identified in 3 monoclonal components in that beta region that Dr. Barr had mentioned earlier. And she had low immunoglobulin levels, IgA and IgG2, and she had an elevated kappa light chain with an elevated ratio of 3.95. She was seen, and this was kind of known to me, and then she was in process of going to see hematology, went to hematology, got the bone marrow biopsy, and that came back with a less than 10% clonal plasma cell. And for further discussion, we have Dr. Browning.
Great. Thank you very much. So, I think this is a great case. I think with this patient appropriately in the setting of hypogammaglobulinemia and increased frequency of infections, both of which can occur across the spectrum of monoclonal gammopathy, she had this paraprotein identified. And if you can advance the slide. So importantly, what we want to talk through is what the patient's diagnosis is. And we'll go through the spectrum of monoclonal gammopathy. Again, she had a bone marrow biopsy showing less than 10% clonal plasma cells, which in the absence of end organ damage is consistent with MGUS. So she had an IgA kappa MGUS. And we'll talk a little bit about when we think about doing a bone marrow and skeletal imaging and what type of skeletal imaging we are choosing now for our patients with MGUS. As already mentioned, IgA gammopathies are unique in a couple of different ways. The first being where we see the band migrating on the SPEP in the beta region, as opposed to the gamma region, which is where we see the majority of our monoclonal gammopathies or monoclonal proteins. And this may underestimate the burden of clonal plasma cells in the bone marrow. And so with an IgA MGUS, it's important to remember, and we'll talk through why, we never really refer to an IgA MGUS or an IgA gammopathy as low risk. So this schema, again, you've seen illustrates the spectrum of monoclonal gammopathy. Importantly, in our patient's case, if you can advance Noffar, she had less than 10% clonal plasma cells, consistent with an MGUS, with a 1% risk per year of progressing to myeloma. We could go to the next slide. So this table outlines in further detail the definition of MGUS. Importantly, with non-IgM MGUS and light chain MGUS, the risk of progression is to multiple myeloma or light chain or AL amyloidosis. And this is as indifferent from an IgM MGUS, where if patients progress, the majority of the time they progress to a lymphoplasmacytic lymphoma, or what we refer to as Waldenstrom's macroglobulinemia, with an IgM myeloma being very rare. And as you can see across all 3 of these, importantly, the clonal bone marrow cells are less than 10%. With non-IgM MGUS and IgM MGUS, the serum M protein is less than 3 grams. And with light chain MGUS, we see an abnormal light chain ratio and a urine monoclonal protein less than 500 milligrams on a 24-hour urine. And as you can see here in the table with IgM MGUS, there may at least initially be a slightly higher risk of progression compared to the non-IgM MGUS, and the light chain a little bit lower. And we could go to the next slide. So historically, the prevalence of MGUS in individuals over the age of 50 has been reported at 3%. Dr. Barr mentioned that there's a large population screening study that was performed in Iceland where approximately 75,000 individuals were screened for monoclonal gammopathy. And the prevalence that came out of that study was a bit higher at 5% in individuals over the age of 50. And that was called the ISTOP MM study, which occurred in Iceland. Importantly, MGUS can occur up to 4 times more, is 4 times more common in Black or African American individuals, and the prevalence may be high in that population. And then we talked about the uniqueness of IgA type gammopathy. It has been shown in studies to potentially rise more slowly, so the prevalence of it rising more slowly with age, although it's thought to be associated with more rapid progression. And in that same large population screening study, the ISTOP-MM study, the investigators looked at patients with IgA MGUS and compared them to IgG MGUS and found that those with IgA had a higher frequency of detecting clonal or abnormal plasma cells in the bone marrow. And so again, we talked about how with IgA, the M protein may not be a true reflection of the disease burden. And so it's really important to look at IgA level, serum free light chains, and we'll talk about further workup for our IgA gammopathies. So important when we're considering the need for additional workup for MGUS is risk stratifying. And so we do that with these 3 different factors. Individuals who have an IgG type monoclonal gammopathy, a serum M protein in the serum less than 1.5 grams, a normal light chain, meet the criteria for low risk MGUS. And generally in these patients, we, in the absence of any evidence of the slim crab criteria or end organ damage, we are able to withhold bone marrow biopsy aspiration and skeletal imaging. And there has been studies looking at this and show in those that meet all 3 criteria, if we do not do a bone marrow, we miss less than 1% of patients that could have clinical or active myeloma. And this has shown in studies also that this population has an absolute risk of progression at 20 years. It's very low at 2%. Now, all those that don't meet these criteria, we refer to as non-risk gammopathy, and these are patients where we definitely want to at least see them in the hematology clinic to discuss whether or not they warrant a bone marrow biopsy and skeletal image. And historically for MGUS, for many years, we had been using skeletal surveys, which we know now have very poor sensitivity and specificity. And so guideline recommendations is instead to use a low-dose whole-body CT, which we now have available at the York Street campus for our patients. So in summary, in individuals who have a confirmed MGUS, whether that's a low-risk MGUS who don't warrant any further workup, or patients who have a bone marrow biopsy and are found to have less than 10% clonal plasma cells, our management is observation and clinical laboratory follow-up every 6 months initially, and those patients who may be more stable over a longer period of time, we sometimes extend that out to annual follow-up. So before we move to the next case, I wanted to introduce our Smilow multiple myeloma and gammopathies program, which includes, in addition to Dr. Barr and myself, Dr. Natalia Neparitzi, Dr. Terry Parker, and Dr. Elaine Gorshine, who sees patients at our Smilow North Haven location and Smilow Guilford. Many of you may be familiar through Yale Medicine with the Hematology eConsult program that I think may be a good option specifically for patients who have low-risk MGUS or a question of light chain abnormality, either due to age or CKD, or a question of polyclonal gammopathy, which we didn't talk much about, but can be associated with liver disease or chronic infection, connective tissue disorders, and importantly, does not have any risk of progression to myeloma or other plasma cell dyscrasias. And then we also hold an MGUS clinic monthly at our Smilow North Haven location, and patients in that clinic usually are low-risk MGUS or kind of less complicated MGUS patients, and the referral to that clinic is through the same referral process to our Gammopathies program. And so I'll turn it back over to Dr. Cutney.
Great. Thank you, Sabrina. I think there's some good pearls there. Love them. So this next case, we'll look at a 69-year-old male who came to me in the fall of last year as well, with a progressive distal neuropathy, at least over, described as pins and needles in the feet and the hands. He described it as being his feet more than his hands and his left foot more than his right foot. And it was particularly worse in the evening with walking. And there was absolutely no weakness. And he couldn't really identify, exactly when or how it had emerged. It was just something that just kind of slowly developed. And his past medical history is significant for a PVC-induced cardiomyopathy diagnosed in 2005, which progressed to paroxysmal and atrial fibrillation in 2014. They thought that was due to his he was a very high volume runner at the time, and he was successfully ablated and it's held in sinus rhythm since. He did get diagnosed in 2011 with ulcerative colitis, and he was being managed with Lialda, 4.8 grams per deciliter, per day. I'm sorry. He was a frequent sports shooter with lead exposure from attending the indoor shooting range, and his serum lead level was on baseline 20 to 25 since we started checking it. He stopped attending that indoor range in 2019. And he was also, at the time when I saw him for this neuropathy symptoms, he was taking a lot of zinc for his ulcerative colitis for whatever reason. And next slide. Other comorbids included some BPH, prostatic hyperplasia, and some tinnitus. He had a couple of meniscus surgeries in the 2000s. I think both knees were affected. And he was a software developer, played the electric guitar, hence his tinnitus, and a little social alcohol, no illicits. Married, 3 kids, distant smoking history, small amount, 7-pack years. Spent a lot of time outdoors. Of note on the family history, Crohn's disease and dementia. His mother and his father had type 2 diabetes, and his brother had Crohn's disease, and his sister was suspected to have a non-Hodgkin's lymphoma. I couldn't really confirm the details on that. And then we did an evaluation for his neuropathy, and the the notables are that no anemia, normal creatinine, normal calcium. He had no monoclonal bands on the SPEP. He had an IgA lambda that presented on the immunofixation, and normal immunoglobulins, and then his light chain. Is a lambda light chain of 61.2 with a significantly decreased ratio of 0.03 was there. And then end of note too, he had this Lyme antibody that was quite high at 4.0. I treated him for Lyme disease. Symptoms didn't change, so I repeated the serum-free light chains again because, hey, maybe they got better, but they didn't. And referred him on to hematology. And he went on, he got a bone marrow biopsy, and he had 10% plasma cells with the lambda restriction. And we have and for discussion, we'll go back to Dr. Browning.
Great, thank you. So I think what the difference we're seeing here compared to the first case is that this patient does have 10% clonal plasma cells in the bone marrow, which qualifies for at least smoldering myeloma. Looks like he had a PET scan that didn't show any bone lesion. So importantly, with smoldering myeloma, what we're looking to do again is to exclude the slim crab criteria. So no evidence of bone lesions. The light chain ratio was less than 100. And so, he meets criteria for a smoldering or asymptomatic myeloma, which what I think is complicated or challenging is the addition of the neuropathy and question of cardiac disease, which certainly raises concern, specifically for light chain or AL amyloidosis, which can be seen more frequently in lambda-typic gammopathies. So I think we can go on to the next slide. So again, in this case, the patient has 10% clonal plasma cells, significant for a smoldering myeloma. We've excluded crab criteria, and then he has no evidence of the slim criteria either. And so this figure here shows the difference in the risk of progression, as you can see, compared to a 1% risk per year initially with MGUS. In smoldering myeloma, we see at least initially about a 10% risk per year of progression. As you can see, the line flattens out with the smoldering asymptomatic myeloma. As Dr. Barr mentioned, smoldering myeloma is very heterogeneous. And those patients who don't progress, over time start to behave more like MGUS. And, I think we often will alter our management to fit that. So the definition per the International Myeloma Working Group for smoldering myeloma, again, we've gone over this, but a clonal plasma cell percentage of 10% to 60%, over 60% being consistent with clinical or active myeloma, a monoclonal M protein greater than 3, and a urinary M protein greater than 500. This is on a 24-hour urine. Again, importantly, in our asymptomatic or smoldering myeloma patients, we're excluding the presence of slim crab or amyloid, and in particular, ensuring that there is no evidence of bone lesions, and we do that via advanced imaging, either with a PET scan or a whole body MRI, both of which we have available here at Yale. Similar to MGUS, we, in smoldering myeloma, once a diagnosis is confirmed, we look to risk stratify our patients, and most commonly do that with the IMWG 2-20-20 rule, with high-risk criteria being patients who have an M protein or a monoclonal protein in the serum being greater than 2 grams per deciliter, having 20% or more clonal plasma cells in the bone marrow, and having an involved or uninvolved, involved over uninvolved serum-free light chain ratio of greater than 20. So in patients who have a kappa gammopathy, that's the kappa over lambda ratio. If in lambda, it's reverse. And so having that above 20 is a high-risk criteria. And then there's a 4 criteria model that includes cytogenetics that are high risk from the bone marrow, which are outlined here. So translocation 414, 1416, having a gain of 1Q or a deletion of 13Q. And you can see here in the table, in particular, patients with high risk smoldering myeloma, which is 3 to 4 of these criteria, have a high risk of progression at 2 years to clinical or active myeloma with end organ damage of 63%. So to touch very briefly on management of smoldering myeloma, which is really evolving, with our low or intermediate risk smoldering myeloma patients, we are routinely observing them. We do this a bit more frequently than we do, at least initially, with our MGUS patients. So we're seeing them and doing laboratory evaluation every 3 months. And then again, to exclude any presence or development of bone lesions, we get annual advanced imaging, usually with a whole body MRI or a PET scan. Again, the frequency of these evaluations may change over time if patients remain stable. In high-risk smoldering myeloma patients, this is where I think the field is continuing to evolve. And there are differing opinions, I think, within the field. But in patients with high-risk smoldering myeloma, especially younger patients, I think we really consider clinical trials pretty highly. We do have some data about potential benefit, progression-free survival benefit with our immunomodulatory agent lenalidomide, and more recently have a phase 3 study that was published looking at the anti-CD38 monoclonal antibody daratumumab, where there was evidence in high-risk smoldering myeloma of progression-free survival benefit and a small overall survival benefit. And then there still is an option, with these patients to observe them closely. I think there is some thought, again, with the heterogeneity, that some patients will progress very quickly. I think in younger patients, Dr. Barr will talk about our therapy, which often includes 4 drugs. And so treating these high-risk myeloma patients, especially young patients, with 1 drug, there is some concern that we could be potentially under-treating them. And then I think importantly is that patients with smoldering or asymptomatic myeloma, although they may be without symptoms, can have some increased risk of other associated complications like infections, osteoporosis, thromboembolism, and the risk of secondary malignancies. So I think in conclusion, with smoldering myeloma, it is a very heterogeneous disorder. We see some individuals that progress quickly and others who never progress and act more like MGUS, and we tailor our management to that. And with patients that are behaving more like a low-risk MGUS over time, there is a possibility, to have them referred back to their primary care clinician with close monitoring. Again, in this case, I think what's complicated is the concomitant peripheral neuropathy in the setting of monoclonal gammopathy, which I think also often will warrant a referral so that we can evaluate for more rare plasma cell dyscrasias or other neuropathic symptoms, specifically light chain or AL amyloidosis, POEM syndrome, cryoglobulinemia, and with IgM monoclonal gammopathies, again, we can see rare anti-MAG neuropathies and Canomod syndrome as well. So it is, I think, very reasonable in patients with unexplained new or progressive peripheral neuropathy to consider gammopathy panels, and then, if there is a monoclonal protein, refer them to our hematology clinic and our neurology colleagues as well for further evaluation. And I will turn it back over for case 3.
Great. Okay, so we've had 2 cases of IgA monoclonals, and we're gonna give you a different one now. So this is an 85-year-old male, very active, very cognitively sharp. New patient to me in October of 2020. He came to me with a history of hyperlipidemia, hypothyroidism, and some mild aortic valve stenosis. He had a right shoulder and left hip replacement with a subsequent right total shoulder in 2023. Never smoker, married with 2 kids. He was a retired salesman for an industrial cable manufacturer. His mom died in her late 30s from postpartum complications. His father and oldest sister died from lung cancer. His older brother died from a salivary gland tumor, and his second brother of an unknown cause. Prior to coming to me in 2011, more significantly, he developed a mild macrocytic anemia with a hemoglobin of 13.2, MCV of 98. His SPEP at the time during the eval showed a monoclonal band consistent with IgM kappa at 0.8 milligrams per deciliter. Because the IgM monoclonal protein, he went on to bone marrow biopsy, which revealed a 20 to 30% low-grade B-cell lymphoproliferative disorder with plasma cell differentiation, kappa restriction. And we think about Waldenstrom's with the IgM gammopathy. He didn't meet criteria for treatment at that time. So he had his SPEP done every year. And from 2011 through 2019, he was very stable at that 0.8 milligram per deciliter level. In 2019 and 21, the level rose to 1.0. And then in 22, it went up again to 1.4. And then in 2023, it rose to 1.7. His hemoglobin dropped from 11 to 8.4. And he was developing fatigue. So he's becoming symptomatic. He had no other causes for the anemia to explain the drop. His kappa light chain was 3.8, and his IgM antibodies were in the mid 2,622, excuse me. And at that point, decision was made to treat with rituximab. And we want to pass over to Dr. Barr to talk about IgM disease here.
Yes, so you can see here that the spectrum of IgM gammopathies are very similar to the IgG and IgAs, where you have the MGUS and you have this middle stage of asymptomatic or smoldering Waldenstrom's, and then symptomatic Waldenstrom's that needs therapy. So what defines needing therapy is different in myeloma and lymphoma. For example, for lymphomas, we look at B symptoms like constitutional symptoms, weight loss, unexplained weight loss, fevers, night sweats, things like that, feeling just generally very poorly. We look at symptomatic cytopenias, which are mainly from crowding of the bone marrow from the lymphoma or from hepatosplenomegaly, which can also cause cytopenias. Obviously, hyperviscosity is very concerning and should be treated right away. Also, if you have progressive bulky lymphadenopathy, that would be criteria for treatment. Cryoglobulinemia, cold agglutinin disease, and significant neuropathy. It's important to also know that not all neuropathy would warrant therapy. Sometimes people have very mild case and they're fully functional, and we just kind of watch them because, again, you have to assess the risk and benefit. Waldenstrom is also not it's not a curable cancer. So when you assess someone with IgM gammopathy, your questioning and what you're looking for is quite different from when you're assessing someone with non-IgM gammopathy.
Good. And then, to move on from an IgM discussion, we have this next case, which was a 52-year-old gentleman from Ecuador, who's new to me really this past December, but in June of 2022, he went to his PCP, had a urologic symptom, but on the side said, "Oh, by the way, my neck hurts, for last week, and I, just changed my mattress. What do I do?" And the PCPs, looked into it, said no red flags on discussion, exam, etc. He looked over his chart. He had no past medical history, no surgeries. Social wise, he was married with 2 kids, immigrated in 2005, and he works as a graphic artist. So conservative care instructions were provided, and he was advised to come back to the clinic and if things didn't improve. But 4 weeks later, in July, he went to the emergency room at Bridgewater Hospital with worsening neck pain and right ear numbness and right arm pain. He had a subjective fever, he had cough, he had congestion. So he was tested for COVID, he was positive, he was discharged with molnupiravir and PCP follow-up. The next day, he had a phone call, video visit with his primary care doc, mentioned the neck pain again. She ordered an x-ray, but the patient didn't get it done for whatever reason. And he went back to his primary care doc saying, "Hey, I have this neck pain, it's still here." And I think she said, "Well, where's the x-ray?" He said, "I didn't get it done." So he went and got it done, and he had a C3H indeterminate, compression fracture. And an MRI was ordered for follow-up. And 2 weeks later, he got that done. And you see here at the C3 level, under the red circle, he's got a pathologic fracture. It's a burst fracture. It's moving posteriorly and impinging the cervical spinal cord. He had multiple lesions throughout his vertebrae, a rib and a humeral head, and no other signs of a alternative cancer identified. And then he had a mild, he had anemia, normocytic anemia of 12.8, normal calcium, normal creatinine. He had an identifiable monoclonal protein on the SPEP that was IgG kappa on immunofixation, elevated kappa light chain, elevated kappa light chain ratio at 0.68. He had elevated IgG immunoglobulins, and he had some spinning proteins on the urine, electrophoresis. But clinical course, he went through a C3 corpectomy and with an intravertebral device placement, followed a few days later by posterior cervical fixation. Tissue pathology from the burst fracture showed sheets of plasma cells, CD138, kappa light chain restriction. And then a few days later, had his bone marrow biopsy done, and 20% kappa plasma cells identified. And back to Dr. Barr.
So I was so excited to talk about myeloma that I speeded ahead. So this patient does have a diagnosis of multiple myeloma. He has definitely bony lesions, has some anemia, and actually, in fact, the most common presenting CRAB criteria is bony lesions and anemia. I think the key features here is this kind of persistent progressive bony pains that in a young patient, someone might not think is that, concerning, especially we see a lot of patients who are shoveling snow and have some back pain, but that does not go away, so it's like something that continues, something that needs to be evaluated for sure with more imaging. So myeloma is not curable. And of course, that's devastating for patients to hear. And as I show you here, it's categorized by multiple relapses. The first remission or response to therapy is often the longest one. And you don't really have numbers here, but on average, these patients have a first duration of response of about 5 years. So it's quite good. And then once they relapse, they get another therapy. And then with each relapse, it shortens. We do kind of classify as early relapse and late relapse, mainly for kind of treatments, different treatments that are approved for these particular situations, and they're a little bit relevant for a few slides from now. So in terms of epidemiology, it's definitely not the most common cancer, so 14th most common cancer. It's usually seen in the elderly, median age of 69, more commonly seen in individuals of African American descent. The median survival, you can see here in the green graph here, has steadily improved for the last 2 decades, okay? And it does depend on risk. And right now we're looking here, well, we don't actually have 2025, right? The most recent evaluation from the SEER database is 2021, showing you that at 5 years, if you were diagnosed in 2021, the chance of being alive at 5 years is 62%. But I can tell you this is very much an underrepresentation of our survival in our patients, and this is probably more close to 75 to 80%. High-risk patients probably do die within the first 5 years, but if you're not high risk, you do have that benefit of longer duration of survival. Majority of the reason why our patients are living longer is because of new therapies. So the initial therapy for myeloma can be quite cumbersome. So it actually involves 3 different parts. The first is induction. We use several drugs together. And after you get nice cytoreduction, here you see burden of disease, and then it goes down with induction. Some patients get a high-dose chemotherapy and stem cell transplant if they're eligible. And then everyone goes on to getting maintenance. And we continue therapy for myeloma ongoing forever, which now as patients are living longer is creating more problems. And we're trying to figure this out, who we can stop therapy for. We know that achieving deep responses, as we can measure by minimal residual disease negativity, achieves good duration of response and overall outcomes like survival. And with our newer therapies that we're using in induction and even in maintenance, we're achieving higher rates of MRD negativity. And this is why our patients are overall doing much better. However, unfortunately, again, it is not curable. So patients do progress. And patients who progress several times historically have horrible prognosis. And this is historically 4 years ago, okay? This is showing you patients who have had 3 relapses. The chance of them responding to the next line of therapy is only 30%. And even if they do respond, they tend to progress within several months, usually less than 6 months. And they often die within a year. What do we have today? This is quite different. We are now in the era of T-cell redirection therapies, which is a type of immunotherapy that engages the T-cells or uses T-cells to identify the cancer, myeloma, through an antigen, which is a marker on the cell surface of the myeloma, identifies it, attacks it, kills it. So this is done through 2 different ways. One is called a bispecific T-cell engager, which is basically an antibody, as you can see, shaped like a myeloma monoclonal protein, which one of the arms binds to the T-cell and the other one binds to the myeloma cell. The other T cell redirection therapy is a CAR T cell, which is basically a T cell that's engineered to have a receptor that recognizes the myeloma and kills it. And the T cells are kind of superstar T cells because they have co-stimulatory molecules once they get stimulated. So why are we so excited about these T cell redirection therapies? Again, historically, these patients who received these therapies on clinical trials would have had a 30% chance of response. And indeed, a lot of the treatments we use now up front, they got approved by the FDA because of a 30% response rate, and we were excited about that. And again, these patients who've progressed 3 times, they usually, even if they respond, progress within a few months. So this is a busy slide, but I want you to focus on 2 things. The first is in the orange box, the percent of patients responding. First, I show you here 3 different types of bispecific T cell engagers, and in the second box is the 2 types of CAR T cell therapy products. And you can see on the bottom in gray, the chance of patients responding is more than double in the bispecific T cell engagers, and even close to 100 in this CAR T cell product, cilta-cel, 97%. Only 1 of the patients did not respond in this clinical trial. So this is great, unprecedented. Now in blue, our bar is showing you the number of months where 50% of the population progressed, or in the other, the cup half full, half empty, 50% did not progress at this time point. And comparing to the 6 months or less historically, you can see these agents are doing far superiorly, with cilta-cel going on about 3 years. So on average, patients have a duration of response of 3 years. Again, unbelievable in these patients. And because these are so useful and efficacious in this late relapse, they've been tested earlier and were approved in early relapse and are now being tested in frontline therapy and even testing against transplant. We'll know more in maybe 5 to 10 years. So CAR T is a little bit different than other therapies we use because it requires manufacturing. So I just wanted to show you what this entails, what patients have to go through. First, we have to collect the T cells from the patients through apheresis. Then they get shipped off to the manufacturer. They separate the T cells, then they genetically modify them to express the chimeric T cell receptor. Then they grow, and then they get brought back to the patient and infused like a regular blood transfusion, similar to that. This here show you a highlight of what this CAR T, what the receptor looks like. So there's a binding domain. Again, this is to a protein called BCMA. Ida-cel has 2 binding domains, and cilta-cel has 2 binding domains, and ida-cel has 1. Now, a major difference between CAR T and the bispecific T cell engagers also is how you administer it, which is relevant for patients. So bispecifics, we don't stop therapy. We give it every week or every 2 weeks and sometimes every 4 weeks, depending on the product. But CAR T is a one-time treatment, which is really nice for patients who've been treated for many, many years continuously. So just to close on the myeloma category, a lot of the patient care happens with us, so you don't see it as much, but you do see them once in a while. And there are some comorbidities that can be exacerbated by our treatment. Steroids are often used in many of our regimens, so this can worsen hypertension, diabetes. I mean, we might need more support from you guys to help manage that. Carfilzomib, which is the 2nd-generation proteasome inhibitor, can also lead to hypertension and heart failure. And many of our treatments increase the risk for infections, often not opportunistic, but now with the T cell redirection therapies, we are seeing some more opportunistic infections. So it's important to recognize that, and with an infection, let us know what's going on so we can further assess. And lastly, I want to end by showing you the gammopathy pathway that is in EPIC. And it's a busy slide, but I want you to know it's there. And you can see that it guides you through if you have a monoclonal protein on SBEP or not. and showing you the monoclonal gammopathy screen panel here, which makes sure you're ordering all the paraprotein evaluation that we need, and also some key information about when to refer urgently, when to not refer urgently, when to repeat labs and reassess. So to close our talk today, these are just some summary points that we want to highlight. First, we showed you how it's important to recognize what is normal light chain ratio, how age and renal dysfunction can affect these. We showed you what low risk MGUS is, what is the definition, and that this often can be managed by primary care doctors if or co-managed with us. When to urgently refer patient, CRAB criteria, certainly things that make it in IgM gammopathies, things that kind of are red flags is new progressive neuropathy or other symptoms diagnosing Waldenstrom. And lastly, it would be wonderful if you can look at the gammopathy pathway if you have a positive finding and tell us if it was helpful or unhelpful. How can we improve this pathway? And also there is some education material for MGUS to bring to the patient to reduce anxiety.
That was terrific. A real everything you need to know from A to Z, or maybe A to IgG. I don't know, IgM. That we have a couple of questions, and we are getting near the end of the hour. One is the usual, is there a CME code? And Renee, if you can just type in that. I think what we found before is if you're here, we end up getting you credit, as long as your name shows. But one question from Dr. Zarku Power is there robust research to link the risk of multiple myeloma to pesticides, Agent Orange, or other chemicals? There are sets of patients in her panel who have asked her opinion on that, pertaining to themselves and relatives. And if there's no robust research, why not?
So I'll say Agent Orange, definitely. That's a definite risk factor. Pesticides? I don't think so.
I'm not familiar either with pesticides. One thing I did want to add is there is emerging evidence looking at connections, associations with components of metabolic syndrome, specifically obesity and diabetes, and both development and progression of monoclonal gammopathy, and some studies looking at the potential for preventative interventions, because I think the thought is just kind of the level of inflammation, but I think we don't know exactly what the connection is.
Drew, do you have any other questions for our panelists? You've been knee deep in this, and you have an internist opportunity to be face to face. Any additional ones?
I think I had a couple of I guess the IgA, like we had two cases here with IgA. We had, nothing detected on the SPEP. We know that the IgA migrates, through the into the beta, the beta, what blank on my name on the term here, the beta region. Is there, I guess the question is like, I guess if it's high risk, right? So how do you, when you're going by IgA levels and light chain levels to see if there's any progression of the disease, is that always 100% reliable? It does. So does I know there when you do a bone marrow biopsy, you're more likely to see like more plasma cells in IgA, right, relative to IgG. So do you see a direct correlation between the IgA protein or the free light chain quantification and cell, progression of the disease? Is that reliable?
That's a very good question. I mean, generally, we look at everything. When patients progress, even if they have myeloma or if they're MGUS and they're going up, the IgA typically goes up first. And then the M spike will rise later, several months later. So that's why we look at both. Again, the trend holds true for the most part. When there's more clonal plasma cells, there's going to be more clonal protein or IgA or light chains. But it just might not be like a one-to-one representation, but the trends hold true.
Okay, that helps. I think it's really important for like primary care docs to recognize that low risk category. You know, the 3 criteria where it's the IgG, M protein, the less than 1.5 milligrams on the SPEP, and then the normal serum free light chain ratios. I think, you know, we see something like this and we're like, oh my gosh, I don't want this to be my own, you know, monitoring, you know, responsibility. But I think that's a key nugget for me, looking at this talk and going through this talk. The difference, you know, the IgM, you have to think Waldenstrom's, you know, and then the IgA is always a low risk, needs that biopsy. I think those are key take homes from my standpoint. I guess the question going back to the toxins too, which and the monoclonal proteins, but can the gentleman in this case who developed the IgA lambda with the false positive Lyme, etc., he blames things on his COVID vaccine, right? So he got COVID vaccine, he developed this neuropathy, and we found this issue. He developed ulcerative colitis after his COVID vaccine, and so he's moving towards that realm. I'm not saying anything is you know, I'm not buying that story a whole lot, but at all. But you know, thinking of antibody, like, is there a correlation between any autoimmune syndrome or a kind of stimulation of B cells in some way and increased risk of these disorders? Like, you know, COVID vaccine, we're stimulating, you know, antibody production, but not saying causation. But is there any discussion of that, or is there any similar concerns being brought to your attention?
Yeah, I think these are questions we get as well. I mean, I think there is thought to be association with autoimmune inflammatory disorders where there's kind of constant stimulation of B cells, like you're saying. You know, I'm not aware. There was a small study presented as an abstract looking at change in monoclonal protein after COVID vaccines, and there was no evidence of progression. So I'm not aware of anything kind of larger than that, but that's a question that comes up a lot from our patients. But you know, that from that small information, I don't think we think there's connection, at least in patients that have MGUS, you know, don't progress to something more.
Yeah, I mean, that's
Gonna
good.
just cut us off because we passed our hour. And I so appreciate all of the preparation that you all did to bring us all of this information. This was really helpful. And if there are others who you think may be interested, please feel free to share the link to watch afterwards. We thank you for attending. And we'll see you next month when we have colorectal cancer prevention and screening as our hot topic.
Thanks, everyone. Bye-bye.
Thank you very much.